हाँ जी सर बिल्कुल.
Question is that you have a patient who had been stuck in a household burn. Okay, so now that patient
Okay
is
sir.
to the emergency, and like you are being called as emergency care. How will you approach the patient? That was closed like a household burn because of flame flame inside kitchen, for example. Okay.
Okay sir. Okay sir. On our arrival to the scene, I will call for help, and I will assess my patient as a whole. And starting with the airway breathing circulation, I will start management of my patient in the way that I will assess his airway breathing. And as you said that it's a case of fire household injury, so there must have to be obvious that there must be inhalational and as well as fire burns of must be there in the patient. So starting with the airway management, I will first evaluate this patient, and as soon as possible, without wasting the time, I will try to take the monitor, attached monitor on the patient, and check the saturation. And if the saturation is dropping, I will intubate this patient. And if patient is BP-less and pulseless, starting with the CPR and going to that towards that, not wasting time for intubation, I will start the CPR first. And if the patient is maintaining his circulation, not asystolic, then what I will put the two large IV both cannulas and start rehydration of this patient according to rule of 9 burn from the ICU. In that, we use the formula of 4 into total body surface area into percentage burn, and will give half of the water in first 8 hours and the remaining in the second hours according to the total percentage of the body burn. As along with this, I will try to arrange the ICU bed for that patient, because this patient might be needing the intensive care afterwards. Along with this, I will go toward assessing the secondary injuries like fractures and other thing. Along with that, I will call to the hematology department after assessing the quick ABG and the hemoglobin status of that patient, and send to emergency labs like CBC, UC, and will get X-ray after doing that chest intubation of that patient. And uh, and intubation will be in manual inline stabilization in line stabilized manner, because I don't know whether the patient have injury or not. And furthermore, AB circulation, and
ठीक है,
will
मैं
continue.
आपको interrupt करता हूँ. I will just interrupt you. Actually, what you have done, you have told a number of things, but a number of things you have missed. Like in this case, you did not mention about airway edema. Even if the patient's airway is clear,
Yes.
with inhalational injury, you will be suspecting airway edema. Okay, so you will
The difficult
anticipate airway obstruction, and you will try to intubate. This is number one. Number two, you will be thinking about carbon monoxide poisoning. Okay. So in
Yes.
assessment, airway breathing circulation, and any injury, maybe patient became unconscious and fall. So that is why I have written neck injury. Okay. And then another big option will be fluid therapy. Okay. In assessment, you will have to get few answers. What will be those answers? That will be answered about degree of burn. You did not mention about degree of burn. Okay. And then extent of burn. Extent of burn.
Okay.
And then area of burn involved. You did not mention, because you have very little time, right? So you have to mention very quickly these things. What is degree? What is extent? What is area? You don't need till the time they are not asking you the rule of 9, this. You will say, I will assess the degree. I will assess the extent, how much percentage of body is involved, and what is the area involved, because area, the burn in the foot is not as area of burn in the chest. Okay, because burn in the chest will result in 18% difficulty, even if there is no inhalational injury, because of where there will be edema, and patient may be having obstruction of the airway because of respiratory involvement. Okay. And another thing assessment will be that a normal patient who has no other problem and a patient with already have some COPD or any respiratory involvement, the effect will be a little different. Okay.
Okay.
And then you will be the rest of the thing will be just like any ACLS, ATLS, for example, because it's not purely trauma, but it is like you have to see in the all the things which you are looking at, and then in this time 3-4 minutes will already be gone. So you have because now you have spoken nice, mashallah. Just add these things which I have told you. Okay. Airway.
Okay, sir, I will.
Airway and carbon monoxide. I will repeat again. Assessment of the burn. Okay. So you use this word because burn is also a hot topic. It may be asked. Either it comes with trauma or it comes with burn, or even if they can, if you want to combine it, they can ask you about blast injury. Okay. So blast injury will combine both burn and both of the things. Okay. So because in burn there are chances of patient going in sepsis. There is chances of patient having too much dehydration. Okay. And then if they want to ask further question, you will be asking first of all will be the degree of burn, degree and extent of burn, and then they can ask you about fluid therapy. And then they can ask you about whether you will like to give crystalloid versus colloids. Okay. So you just have to identify the extent, and then those formulas, the Parkland 4% burn,
total body
4 ml per percent burn, 4 ml per percent burn. Okay. So that is what is there. So if they ask the question of burn, I think you just have to focus and carbon and further question will be according to their key, what they want to ask. If they want to ask about carbon monoxide poisoning, you can tell about how to quantify it, like mild, moderate, severe, according to the levels. And then what are different options? Either it is air, you give in air if you are giving oxygen, 100% oxygen, or you are giving hyperbaric.
Hyperbaric oxygen, yes.
So there will be a shift of oxygen hemoglobin dissociation curve to the left, and patient will the cherry red color. Okay. So these were the things they want to ask in details about carbon monoxide poisoning. And airway burn, soothe, any signs of respiratory, that's what we discussed recently in respiratory distress. Okay. So you in airway breathing circulation, you will be looking at these things, and you can say that extent, and it will be presenting like airway, upper airway obstruction usually. Okay. So upper airway obstruction. More, of course, it can have signs of lower airway obstruction as well. They're reactionary. There will be bronchospasm, and then after you intubate, you can have a bronchoscopic examination. Okay. So they can have lavage if they want you. And you did not. Yes. Another remember one thing, that in such case you have to say multidisciplinary approach. Okay.
Approach,
and if the is gone after 24 to 48 hours because of extra junctional acetylcholine receptor, there are chances of hyperkalemia.
Hyperkalemia, yes.
You will not use succinylcholine. Initially, you can use it. Okay. So that's what I think. These are the points which you should not miss when you are dealing a patient with burn. Okay. So next question I can ask you about, which I yesterday sent a paper as well, about spine. Okay. So if what may be the concern if you have a patient with spine injury? This is one thing. And what are the things which they can ask you in different scenario? I will just tell you. Spine injury, and they can ask you about spine surgery. Okay. And they can ask you some diseases which are involving spine, like, for example, ankylosing spondylitis, but more commonly scoliosis. Okay. So these are the things which they can ask you, and of course, trauma, tumor. Okay. And unstable spine as occur in Down syndrome and rheumatoid arthritis. If you just scroll, I will just try to. it will take time. Anyways, there actually I just made a mind map about it. I was just discussing with one of the resident here. So I just made a mind map, and that so they can have different questions, but that there will be some common things. If there is injury, okay, injury may be acute or chronic.
Chronic.
Okay, so this will be one question. Then other question will be that whether it is anterior versus posterior. Okay, and whether it is complete versus hemisection, and
Okay.
whether what level it is. Okay, level at if it is cervical or thoracic or lumbar. Okay, so the thing whatever is happening is because of this thing, and then there are the word ascending and descending track. Okay, and the senses or things which you are noticing is pain, sensory system, motor system, okay, and autonomic system. And whether it will be contralateral, I'm just making it simple, contralateral versus ipsilateral. Some things will be lost as at contralateral side, and something will be at ipsilateral, like motor system will be ipsilateral.
Ipsilateral, yes.
The side of spinal cord where it is done, it will be the same side.
Same, yes.
And contralateral temperature. Yes, another thing is in senses, you can divide it in touch and proprioception. Okay, and in autonomic, it may be a sympathetic system and also temperature. So if you are just telling, they can ask you anything about details about this thing. If it is acute, in addition to the neurological problems, what will be there is spinal shock.
Okay, sir.
Okay, so there is a severe hypotension. Okay, and if it is cervical level, the another thing will be apnea and need of mechanical ventilation. So for hypotension, you need to give fluids and vasopressor. And third thing is high dose steroids.
Steroids, yes.
Okay, in addition to that, whenever there is hypotension of that, like you will say, in addition to standard 1, standard 2 monitoring, I will be doing invasive monitoring.
Invasive monitoring, yes.
Okay. So you can tell like that, spinal shock, and then if there is apnea, you need to mechanically ventilate and shift the patient to ICU. Okay. So these are the rest of the things are common. Believe me, the rest of the things are common. Usually, and these things you have to take care whenever there is head injury. You have to expect any spinal injury. Okay, so there will be some things which will be related to it. Okay. So if, for example, if there is any disease like, for example, scoliosis, what are the things which you should be remembering in scoliosis?
Anatomy of the body, like anatomy of the ribs and anterior posterior diameter will be the disturbed.
Okay.
Patient lung compliance will be disturbed.
Okay, so first of all, you just identify scoliosis as whether it is congenital
or
acquired. Okay.
Acquired, yes.
This is one thing, because what will happen if it is congenital, there are more chances of cardiovascular respiratory system involved. Okay. If it is acquired, there will be some trauma, or there will be some neuromuscular disease.
Neuromuscular disease, yes.
Because there will be weakness. Okay. So yeah, like for example, if the patient has cerebral palsy, they later on they can develop scoliosis. If the patient has Duchenne or any neuromuscular disease, this patient can develop scoliosis. And there is another trend of scoliosis is kyphosis. So sometimes they are kyphoscoliosis. Okay. So what is the problem with respiratory system? Things like restrictive lung disease. Okay.
Restrictive lung disease.
And then what will happen? The same mechanism which I just told you. There will be increased pulmonary vascular resistance and then cardiovascular involvement. Pulmonary hypertension and then cardiovascular involvement. Okay. So this is very
Right.
simple. If you understand this thing, you will never actually, you should be knowing any problem, you can divide it like what is the cause. Okay. And what is the systemic
Yeah.
involvement. So this will be like that. So then you can say, if you want to assess the cardiovascular system, you will be having ECG and echo. Okay. If you want to
Yeah.
understand about respiratory lung disease, restrictive lung disease, you will be doing ABGs and
That
pulmonary function
flow,
test,
you can
flow volume
test
loop, and not
and
not the last thing, but the first thing, chest X-ray. Okay.
test X-ray.
So this is not common for, if you will try to think only about scoliosis, what are investigations are needed, then you may be forgetting about it. But actually this is for any respiratory problem. You are, whenever you know this 3-leg tool. 3-leg tool is not only for for thoracic surgery. Think about it for any patient. Any
Okay.
this 3-leg tool, what is that one? One are some physical things like this mechanical, like you do in the form of flow volume loop and spirometry.
Yes.
Okay. The other things are for gaseous exchange.
Gases exchange.
Gas exchange, like which you do in ABGs, or to be very
ABC.
specific, lung diffusion capacity. You don't do it in every patient, but actually this is the thing. And the third thing is, this is one, and the third tool is cardiopulmonary exercise tolerance, or so it is nowadays they do the CPEX test. Okay. Cardiopulmonary exercise testing. But actually this is the whether the patient is unable to correlate the respiration with CVS. Okay. Like you have adequate gas exchange, and then there is adequate cardiovascular system to send it throughout body to utilize it. Okay. So this is just a basic of cardiovascular and respiratory evaluation. So an additional thing which they want to listen from you is Cobb's angle. Okay. They can ask you that if it is the highest, so you will be taking this one, and this is the, so this will be one, and then I think this is Cobb's angle. I forgot it. Just have a look on it. That they can ask you how to measure Cobb's angle, and as severe the Cobb's angle will be, as severe there will be chances of post-operative problems. So usually they do it in staged. So another thing which will be related to it will be spine surgery. Common thing is prone position. Usually, of course, they will be doing majority of spine position, and then they will
Position related
chances
changes.
of,
Yeah.
yes, position related thing. Then they are asking for hypotensive anesthesia. Okay.
Yes.
Then they were asked, there are chances of sudden bleeding. Okay. And then they are doing evoke potentials or versus wake up test.
Wake up test.
Okay. So these are the things, the rest of the things are common. Whenever there is bleeding, so you should be thinking about preoperative, and then you can expect bleeding. You can say about any bleeding thing which we discussed, that you can have a this hemodilution. Okay. You can have cell saver. Okay. You can have this hypotensive anesthesia. So you can just tune your brain, scoliosis, extend, what is the cause, what is the extent of damage, and then how to evaluate any systemic involvement, and then rest of the things are the same. Okay.
Okay.
So, and rest of the thing usually they will not ask you, but if for example they can ask you about spine fixation. Okay. This is least likely to be asked to you people in MCPS. I don't think so they will ask you, but you can have a look on these things. Spine fixation, this discectomy, and another thing that usually they are doing it in posterior, but there is one procedure, anterior cervical spine fixation. Okay. Anterior cervical spine fixation. So this is a procedure which they do it in, and whenever there is cervical involvement, there can be severe hemodynamic response because they are near the vital centers. So they can there may be involvement, and even the carotid area is there. Okay. So there may be sudden
Yes.
bradycardia, tachycardia. So this is only thing we should be knowing. If they are asking you any question, as I discussed, you might have listened that there will be disease related concern. Okay. There will be surgery related concern and there will be patient related. So keep
Patient.
these things in your mind and then you will be able to speak out. 3-4 minutes is nothing. If you are talking logically, they will not stop you. But
Okay.
try to first of all, for any the remaining few days, if you make mind maps for all diseases, for maybe 50, you target 20 or 25 or 30 diseases like that, which I've told you. Believe me, the target disease may be diabetes, hypertension, anemia, COPD, asthma, okay, heart failure, and then sickle cell disease, okay, hemophilia, this thalassemia, and these rheumatoid arthritis, scoliosis. Just tell me what they will ask. What else is left? They will ask
No,
you
nothing.
any one of these, and the common surgeries. Common surgeries, for example, you make a plan for laparotomy. What will you give? Analgesia, laparotomy, cholecystectomy, hernia, okay, and then appendix, cesarean section, ruptured ectopic, okay. So just make a list. If you make a list out of it, it will become very easy for you. Okay. So now I will ask you a scenario. Now I will be silent and you answer. You have
Yes,
a
sir.
patient, 35-year female, 30 weeks pregnant, who has a fall in the home from stairs. So
Okay.
how will you approach the patient?
Sir, on arriving to the patient side, I will assess I will evaluate my management in involving the multidisciplinary fields. Like I will involve the obstetrician, I will involve the intensivist, and I will myself do airway, breathing and circulation examination. And if she is desaturated, and I will start putting the monitor first and call for help. Yes, call for help from the multidisciplinary team, just like that I have told you already. Okay, sir, first of all, I will assess the patient airway, breathing, circulation, and if she's desaturating and she needs oxygen, I will put on the oxygen mask. And if she's apneic, and I will start putting the advanced airway. And if she's asystolic, like I will start the BLS and any other thing like that. And along with that, I will if she need intubation, and as there you tell me that there is a history of fall, so I will do manual inline stabilization of the cervical spine. And along with that, I will call the obstetrician team to assess the patient baby status, and to do the ultrasound if there is any internal bleed, and if it is there any pervaginal bleed, it must be their side to assess these things. Along with that, I will put 2 IV cannulas and start IV fluid after assessing the hemodynamic status of the patient. And so on. If she is like dropping her GCS, I will arrange for any CT scan. Whatever will be the her presenting complaint, I will move according to that. I will send investigation of like CBC, UC, and acute blood loss. Uh, After assessing and confirming with the ops team, will arrange products accordingly. And furthermore, for observation purpose, I will discuss with the ops team that she need gynae, HDU, or ICU. Whatever she want, I will arrange these things. And if they want to deliver the baby, then I will discuss further with the surgeon what is the plan and what is the mode of delivery she wants to proceed with. and will plan for my anesthesia accordingly.
Yes, you have told a number of things. Just align the answer. Your approach always should be airway, breathing, circulation. Okay, and then you will be called for help, multidisciplinary team, and if you are talking about resuscitation or supportive care in pregnant patient, don't forget about left uterine tilt and
Yes.
CTG monitoring. Okay. In addition to that, rest of the things are like that. Systemic primary survey. You just use this word primary survey to see any like when the patient falls from this one stairs. There may be like patient may go there may be any like what involvement can be the separate one is placental
Other bone fracture
placental
is
abruption.
fine.
Okay.
Yes, placental
Abruption can
yes.
occur. Of course, there will be the same A, B, C, D. There may be some fractures. Okay. There may be some head injury. Okay. There may be some neck injury. So, like,
Yes.
actually, this is just a practice. They will never ask you this question, but this is just a practice.
Yes.
What you should be doing. If this suddenly they ask a similar question, you should be thinking that this is a trauma plus pregnancy. Okay. So the things are not
Yes.
1 + 2 is equal to 3. Okay, that's it. That if trauma in
Okay.
pregnancy occurs, you will be just having multidisciplinary team approach. Your concern is not only to save the mother and save the baby. Priority is given to the mother.
Both.
That's it. So rest of the things you
Initial.
have told anything, and you did not told about perimortem cesarean section. Okay. So this is another thing.
Okay.
You should never forget that if the patient goes in, not of course stairs, it will not be caused by falling from the stairs, but I'm just practicing, making you practice so that whenever there is a pregnant patient in trauma going towards CPR or any, so you have to mention this, that if they are the resuscitation is not fruitful, you have to do perimortem cesarean section. You have to do, if the patient is you are optimizing the patient, just use the word resuscitation, management and evaluation will go side by side. Okay. Thoracosystemic involvement involving any cardiovascular respiratory system, and in the abdomen, of course, you will be looking at the patient in bleeding, and because by the fall placental abruption can occur, patient can go in labor. Okay, because this is a stress, patient can go in labor. This is 30 weeks. So patient can, so you will rest of the things will be guided by whatever they are asking you. Okay. And whenever there is any hemodynamic instability, you can say that you will approach or attach the monitors, and if you will consider, if needed, invasive lines. Okay. And of course, fractures and head and neck care and everything is the same. So another scenario, because they will be asking you, this patient, that a baby vomiting, okay, and fever, baby 4 years old baby, and they are abdomen is distended. Okay, so they are suspecting intestinal perforation because of typhoid.
Okay.
Okay, so how will you approach?
Sir, I will evaluate my patient according to history, examination, and investigation. I will approach this patient, but firstly by airway, breathing, circulation. I will check the monitor and check patient ECG and BP and saturation. Fever, as you tell, he is having fever already and having history of typhoid. So the treatment will be according to history, examination, and labs investigation. And I will first give my priority along with preparation of theater to stabilize patient according to the labs parameter. Like if he's having some electrolyte deficiency, so I would like to correct these. I would like to cool down the temperature, and if he's desaturating, so I will apply the oxygen, And furthermore, I will arrange post-op ICU as well in advance from ER. And as this is the baby, so there must be chances of anticipated difficult airway. I will first discuss the surgeon what mode of anesthesia and to what level he wants, and then I will decide for my anesthesia plan. And if it looks like that the patient is needing intubation, so I will already assess that it must be a difficult airway. And during intra-op preparation, I would like to put two large IV bore cannulas. I will already keep the fluid warmers, rapid fluid infusers, and bear hugger for the baby, and keeping the normothermia, and avoid excessive entry and outside movement of the OT as the patient is baby, and baby are more prone to hypothermia, and hypothermia could lead to any other issues. So I would like to proceed like this, sir.
Yes. Okay. So again, the same things, same mistake actually you are doing. This is a 4-year-old baby, so you can say that there will be considerations related to the. You don't need to say this thing as first, but you will be saying that you will be evaluating the baby on the basis of history examination. You will be discussing with the surgeon what is their plan, and the things which you can face in this patient will be vomiting and fever. So there is a chances of dehydration. Okay. So you will,
Yes,
your focus answer should be according to the dehydration status, conscious status. Okay. So these and patient, of course, if the patient is too much drowsy, there may be hypoxia. Okay. So these three things usually this will be in your, it should be in your mind. And in discussion with the surgeon is you will discuss about laparoscopy versus laparotomy.
Okay.
Because they do this surgery in laparoscopic as well. So you can say if it is they are doing laparoscopy, the concern related to the laparoscopic surgery. Okay.
Standard and visiting.
And then there will be a you will be considering it as full stomach. Okay. Because
Full stomach, yes.
so there are chances of aspiration. So you need to
Aspiration.
do
So
rapid sequence induction. Okay. So the babies, because of physiological, pharmacological, and anatomical changes, they have already suspected difficult airway. Okay. And so you need to prepare equipment accordingly. You need to prepare the doses
emergency drugs.
IV line, because this patient might need fluid resuscitation. So you should have good IV lines. Okay. So you will be needing different equipment. Now you can make your answer prolong, and then you can say that my patient might need post-operative HDU care, ICU care. So you will be consulting the this one PICO, and this is 4 years, so it will be PICO. But if it is younger, you can write an ICU. Okay. So these are the things which should be, and that when the time they deflate, this is at that time patient can decompensate, time of deflation of abdomen. Okay. Whether it is laparoscopically or open, at that time patient can deteriorate. So that's what I write here. Logistics, you can use this, remember this word logistic for everything. Preparation of OR temperature, equipment, medications, informing the staff, and because whenever there is fluid resuscitation, you can say that it is you will be discussing. Whenever there is a ruptured bowel, there may be bleeding. Okay. So
yes, sir.
Perforation. So there will be you should be cautious about the transfusion triggers, because in babies the transfusion triggers, you have to be meticulous about them. So these are the things you, and another thing which I missed it, that you will be treating also on the lines of sepsis.
Sepsis, yes.
So you will be sending the cultures, and it's starting antibiotic. Initial optimization, you can say these things, and fluid resuscitation. Okay.
Right.
Discussion about the surgeon, what is their plan. Usually they will do, they may do stoma. Okay. Or they may do end-to-end anastomosis. Okay. So this is just actually number of things will be common to any laparotomy. In any laparotomy, there will be hemodynamic instability, dehydration, and then one thing I did not tell you is standard 1, standard 2 monitoring, special urine output. Okay,
Yes.
because this patient will be at risk of having acute renal shutdown because of dehydration. So apparently, when I give you the scenario, you must be thinking, oh, it's very difficult. But baby, laparotomy, dehydration, infection, and then rest of the things are self-explanatory. Okay. Induction,
yes, sir.
Rapid sequence reduction. Fluid, you need fluids. Muscle relaxation, nothing special. But rather, if they are doing laparotomy, they need good muscle relaxation. Okay.
Yes.
So, and then multimodal analgesia. Multimodal analgesia with paracetamol. If there is chances of bleeding, you will give this one NSAID with caution. Okay. Rest and post-operative for analgesia, you can give Taplock. You can give this one wound infiltration. Okay. So these are the things which you as per anesthesia plan. So in this scenario, if they ask you this scenario, they will ask you about to assess the dehydration level, whether it is severely mild, moderate, or severe dehydration. This is one thing. The other thing will be concerns related to pediatric patient, and they in the same question they are asking you about sepsis as well. Okay, the main basics of the things usually. Because if the patient is now you are giving fluid resuscitation and it is not stable, then the patient may need norepinephrine. Okay.
Yes.
Usually heart support is not needed in this age group usually, but of course you have to follow the sepsis protocol. Okay. Sepsis protocol.
Okay,
usually, actually because if you are just touching them, even that is enough. In initial assessment, you will be assessing according to the dehydration status. You will be discussing with the surgeon, and rest of the things are the okay. So I think this scenario is finished. Then another scenario. You have a patient with COPD, 55-year-old, presented with the fractured shoulder. Okay, so what will be, how will you evaluate the patient, and how will you proceed for the surgery?
Okay, sir. I will evaluate my patient according to the history examination and investigations. And in history, I will ask detailed history about the patient's COPD and associated comorbids and the drugs, complying to drugs or not, and onset and duration, last exacerbation, history of last hospitalization, history of cough, history of chest infection, history of night sweats and fever, history of orthopnea, history of dyspnea. I will assess functional class patient after asking few questions like how much stairs he walks, and further I will do investigations like CBC, UC, and I will ask patient for the PFTs and all these like ECG, echo, and furthermore I will ask about the treatment on him which he is, like he's taking any broncho agonist, beta agonist, and is he on any oxygen therapy, and is he having any sleep obstructions and daytime somnolence, like these. After all these, I will discuss with the surgeon what is the mode of the and depth of the anesthesia he requires, and after discussing with this patient comorbid COPD, I will also would like to add my few comments to that regional would be better as compared to general anesthesia. And along with that, I would like to plan for, after discussing with the surgeon, I would also like to plan for the block, any type of block, if he is feasible with, and and as he is 55 years and already known case of COPD, I will further already arrange the uh, ICU or HDU, whatever, according to the patient severity of the disease and exacerbation history. And furthermore, after looking at the CBC, UC, I will preoperatively normalize my patient on basis of these tests. And if he wants any other approach of a cardiovascular and pulmonary team, I would also evaluate the patient according to the labs and will further suggest if he want to consult, if he need that consult or not.
Okay, so Sarish, the things which is in COPD, the things which you should be knowing, what is the extent of COPD at that time? Okay.
Okay.
This thing, of course, because this is shoulder. For example, if this is sort of urgent surgery, okay, so
Yes.
you cannot delay it for a long time, but you can still optimize the patient. You can do some optimization quickly. So that's what you will be saying, that you will be discussed with the surgeon. What is their plan? How much is the urgency? How much time you have to optimize the patient? Because you will be seeing any reversible component of COPD. Okay, extent and end organ damage. This will be one thing. Okay, like for example, if the patient already has heart failure and patient is dyspneic, patient is unable to lie flat on the bed. So you said you have to consider these things, but immediately you can have a quick PFR and ABGs. PFR will tell you a number of things, and you can have a quick chest X-ray to see any emphysematous bulla or any preoperative pneumothorax, because these patients have spontaneous bulla rupture. So this will be one of your consideration. Okay, so then you can immediately give some antibiotic, chest physio, steroids, beta agonist nebulization, okay, mucolytics, okay, and if for example, if the patient is in heart failure, you can start some diuretics. Okay, if you have elective surgery, you will optimize the patient and target this one, reversible component. Okay, so you said that the regional will be better. So remember one thing, for shoulder surgery, the block which you are giving is interscalene block. So
yes, sir.
There is a chance of phrenic nerve involvement. Okay, so phrenic nerve will be involved. So for example, if the patient has already respiratory difficulty and you block the phrenic nerve of one side, so patient will not be able to lie flat, and patient can go.
Yes, sir.
So it's never a very practical thing. Okay, so you will be saying that you can give it as a part of analgesia with very low dose and trying to spare phrenic nerve. Okay, by some maneuvers, by giving a smaller dose, lower concentration, but still it can occur. So it's not a straightforward thing to give interscalene block in patients with COPD.
Okay.
Even spinal, if you are having any surgery in which you are saying about spinal, yes, spinal will be better, but you have to evaluate that if you give spinal and the intercostal muscles are blocked, patient might not be able to lie flat on the bed, and then you will be in big trouble. Okay, so this thing for generalized COPD. And if they want to ask about the like if it is an elective surgery, they can ask you like in addition to all the things, you can ask to stop smoking. You can optimize any of these things. They can give us short course of steroids. They can treat any exacerbation of COPD by giving antibiotics, chest physio, incentive spirometry. Okay, so these are and treatment of heart failure. Mucoliter sachet, this is N-acetylcysteine, which breaks down the mucus, and it is then easy to by postural drainage or by chest physiotherapy, they are able to cough it out. Okay, and I have not written here, but there may be chances of pleural effusion in these patients. So if there is any need of drainage of pleural effusion or anything, you may consider this thing as well. Okay, so the rest of the thing will be that according to the surgery, what is the surgery? that what sort of there may be some bleeding in any orthopedic procedure, embolism, bleeding, tourniquet, bone cement. These 4 or 5 things you remember. Not it will not be for every orthopedic procedure, but whenever you are thinking about any orthopedic procedure, think about embolism, fat embolism, thromboembolism, tourniquet, pain, bleeding. These 5, 6 things you should never forget. Okay. And of course, positioning. So this is in the sitting position usually. Position,
Yes,
pain, bleeding, pulmonary
bleeding.
embolism or fat embolism, bone cement syndrome, tourniquet, okay, and choice of anesthesia, analgesia. Okay, so you should be knowing the nerve supply of that area.
Okay.
If you just prepare in that way, the only 4 joints: shoulder, hip, knee, or wrist, or for example hand, it will be easier for you to target. Okay.
Okay.
So these are the common things that and any orthopedic procedure you should remember these things. Bone cement will not be used in every patient, but just keep in your mind. Tourniquet will not be there in every patient, but tourniquet may be there. Okay. And
Yes.
bleeding may be there. Bleeding intra, like for example, if it is a long bone fracture, there will be 1 to 1.5 liter of, for example, in femur, 1 liter at least blood loss. So you will be anticipating and planning for the surgery accordingly. Okay. And pain will be a big problem. Preoperatively, a patient is a fracture.
Yes,
even during transfer, there will be a big problem. Positioning for the block, if you have a femur fracture, okay, so it is painful.
Yes.
And even during transfer, you need to give something. You need to give some analgesia. You can give some femoral nerve block, or there is some new blocks. You can read about it. So, but even if you have a concept that orthopedic surgeries, you can have these problems. Okay.
Okay, sir.
So gynae ops, pediatrics. Okay, one more scenario. QRP. In
QRP, yes, okay.
70 male with diabetes mellitus, hypertension. Okay. So what are concerns? How will you manage?
Sir, is he coming for TURP?
Yes, yes.
Okay. As I will like to evaluate my patient according to history, examination, and investigation. As we know that the patient is already known case of diabetes and hypertension. I would like to elaborate my history of both of these conditions, like diabetes onset, for how long is he taking any medicines, and is complying to that medicine, and he is whether the symptoms or whether the diabetes is controlled on that medications. And I will also inquire along with these that any end organ damage after discussing the patient, like is he having any urinary issues, and is he having any palpitation issues, if he is he having any eye issues, is he having any cognitive impairment. Along with that, I would like to discuss the history of hypertension, and the drugs he's taking, the onset and the duration, and the associated signs and symptoms of that patient. And after that, as he is coming for the TURP, I would like to do some investigation along with his comorb investigation in order to optimize the patient for the surgery. And for pre-op, I would like to keep all the anesthesia emergency drugs ready. And I would first attach the monitor of this patient, pass to IV bore cannulas. We'll discuss the surgeon.
Whether are you giving GA or spinal?
I will discuss the patient. I will discuss the surgeon.
Which is better, GA or spinal?
Sir, I would prefer spinal.
Why?
Because, sir, as we know that a patient is diabetic, so their diabetes and hypertension. So hemodynamically instability, although it's here in both GA and
No,
spinal, but it's much.
If you say hemodynamic instability, so hemodynamic instability is more in
Spinal.
Okay, so you will be caught.
Yes. Okay, I don't have to use this word at least.
So I will stop you here. Just tell me one thing. Why are you telling too much details of diabetes? And this is not a question related to diabetes or hypertension. This is related to elderly patient 40 URP. Okay, so you can, if you want to divide it, you whatever they want to ask, they will ask you. But there are concerns related to elderly patient. Okay, there are concerns related to lithotomy. There are concerns related to TURP surgery. Okay, and there are concerns related to TURP syndrome. So for diabetes, hypertension, I told repeatedly.
Yes, okay, sir.
I think you have not listened to the lectures. Remember one thing, you will use the word that diabetes and hypertension, I will evaluate the patient according to history, examination and investigation to see microvascular and macrovascular complication leading to end organ damage in heart, lungs, brain, kidneys, okay, eye.
Okay.
So you can say like, because what are the microvascular and macrovascular complications? Microvascular complication is retinopathy and nephropathy. Both of them actually, both of them are alike. So microvascular and macrovascular complication is nephropathy and retinopathy, number one. And macrovascular complication is cerebrovascular disease, peripheral vascular disease, ischemic heart disease. Cerebral vascular disease will be, end organ damage will be TIA or stroke. Peripheral vascular disease, end organ damage will be intermittent claudication, ischemia, gangrene. And in heart, ischemic heart disease, arrhythmias, ischemia, infarction, heart failure. Step by step. If there is diabetic patient, hypertensive patient, there are chances of ischemic heart disease, there are chances of atherosclerosis, there will be ischemia leading to infarction, infarction leading to arrhythmia or failure. So you remember, recall this word. You don't need to tell how much is the drug compliance. No, this is not the, if they are asked, they want to ask you, they will ask you. But you will use this word, I will evaluate the patient on the basis of history, examination and investigation. How is the control and how much is the end organ damage because of microvascular and macrovascular complication related to this disease. So this is the answer which you should have. Another one thing I missed is autonomic system. So autonomic system is very important because it will be evident as exaggerated response to anesthesia, whether it is laryngoscopy, whether it is general anesthesia, whether it is regional anesthesia, spinal anesthesia or epidural. So there will be exaggerated response. Okay. So rest of the things will be according to this. Now, what are the things in this case? What are the things related to airway? Now you can say that the airway problem in this patient will be elderly patient, edentulous, difficult mask ventilation, and because of diabetes, difficulty in laryngoscopy because of glycosylation of joints. Okay. And in induction, there is exaggerated response to anesthetics, whether you are giving spinal or whether you are giving GA. So there may be exaggerated laryngoscopic response and exaggerated hypotensive response. Okay. So this is just for you to know, and then you will say that because in this surgery it is better, GA can be given, but if you are giving spinal, it is better because because there are chances of fluid absorption. Don't use the word TURP syndrome. You can use that the fluid which they are using is hypotonic. It may be absorbed,
Yes.
and it will be causing overload, hyponatremia, and that is the TURP syndrome. Okay. So if the
Okay, sir.
patient is in spinal, it is easier to pick.
Okay.
Okay. So this
Easier to the symptoms, right?
yes. And intraoperative, then you will be say the discussion with what will be the things which you need to say in this patient regarding discussion with the surgeon. Discussion with the surgeon is about the prostate size.
Okay.
And how much time they are expecting time.
Okay.
Absorption is according to the time. Then what fluid they are using. Okay. And you have to discuss about the height, because you will be like minimizing the absorption.
Okay.
Okay. So absorption minimization is by the height, by the type of fluid, by the time, prostate size, and whether there is obstruction or not.
Okay.
What is the importance of asking this question? Because if there is obstruction, there is chances of
More option.
hydronephrosis.
Hydronephrosis. Okay, sir.
Okay, so hydronephrosis and CRF.
Yes.
And then if it is CRF, there are more chances of TURP syndrome, because
Okay.
the patient is unable to handle the fluid.
Okay.
So you will not say that it will happen. So you say that you will be discussing with the surgeon about these things, and if there is signs of obstruction, there may be, don't use there will be, there may be, maybe is a better word. There may be involvement of kidneys because of obstructive uropathy. This is obstructive uropathy. This can occur in ureteric stone, this can occur in bladder mass, this can occur in anything. Okay. So one of them will be TURP, this prostatic hyperplasia. So this patient can have. And another thing which you will be, you can say that this patient might be more risk of sepsis, more risk of bleeding.
All right.
Because this is a very dirty area, so prophylactic antibiotic is of utmost importance. Prophylactic antibiotic is of utmost importance. And they can ask you another question, that whether you can do it in saddle. So the answer is not a good choice, because they will ask you that the area, the dung is prostate. So prostate has sacral supply. So why you are asking to up? So because of bladder distension, they might need to up to T10. Okay. So the urinary bladder supply is from T10. So that if they ask whether you can do it in saddle, so say that if they can handle the bladder distension, this procedure may be done in saddle. But what will be the problems about it? That patient may be moving the legs if you are only giving saddle. This is one thing. And this is more so not in TURP, in TURBT, bladder tumor. Because if it is involving the lateral wall, what will happen? There will be chances of obturator reflux. Okay, which can even cause bladder perforation. Okay, if they are removing the tumor from the lateral wall of bladder, there may be incidence of obturator reflux, and it can create big problem during the surgery. Okay, so these are something additional about TURP, and then they will ask you how to assess the sodium status. So it will be clinical, and then measuring the osmolarity, ABGs. Okay, then you will be calculating. I don't remember the formula. You should be knowing the formula. Okay.
Yes, sir. Sodium deficit formula.
Sodium deficit, and then how you will be called 0.5 to 1 milliequivalent per hour per day. I don't remember. The basic thing is that you have to replace it slowly. Okay. And you can give it with normal saline with diuresis, or you can use hypertonic saline.
Okay.
So this will be about URP syndrome. So there will be signs of overload. Okay, and because sodium involvement, there is conscious level changes. Okay. So if they are asking you a question with multiple comorbidities, try to extract that what is the main question. If they are asking you URP, the main question is not diabetes and hypertension. So don't be distracted. If you use this word, there will be, you have to look at the word I have repeatedly told you, end organ damage because of microvascular and macrovascular complications of diabetes and hypertension. Okay.
Okay, sir.
So control, of course, and of course, you see, it's a big topic. So they may, if they want to ask you about diabetes, hypertension, you should be ready for it. But usually it is control, and how it is controlled by medications, which medications, their mechanism of action, and their side effects. Okay.
Okay.
So and anesthesia relevance. That, for example, if the patient is on diuretics, so there are chances of hypokalemia. Okay. And there will maybe chances of exaggerated blood, like for example, if the patient is on AC inhibitors, so there will be more chances of hypotension. Okay. So rest of the things will be according to the scenario, but you should be knowing this.
Okay, sir.
So Sarish, I think you understand something, and actually the problem is that I wish you listen to the rest of the recordings.